Thank you, Graham. Thank you for the invitation from the organizers. I'm a medical oncologist, so very much deal with drugs rather than surgery, but clearly this is a multidisciplinary problem that requires a multidisciplinary approach. I did want to also just focus on something a little bit controversial, and so I'm trying to give you a feel for where we're up to in terms of treatment choices for a medical oncologist for these patients. Just some disclosures. I've also been involved with a number of clinical trials for the various companies listed. 2011 saw the year that we said farewell to Steve Jobs, and for those of us who've got iPhones and iPads, I think his vision in terms of IT has completely revolutionized our lives. But 2011 also, I think, was a gran-cru year for patients with pancreatic neuroendocrine tumors, particularly with advanced disease. So I just want to take a little bit of time to dwell on two studies that were reported last year. Both of these studies were specifically for patients with pancreatic neuroendocrine tumors, and specifically for patients who had demonstrable progressive disease within the previous year. Just put this into context. In the medical literature, we have numerous, dozens, maybe even hundreds, of small retrospective series, case reports, and small studies with mixed patient populations. So this particular study with everolimus, you can see, had 410 patients who were randomized, and that remains the largest study in neuroendocrine tumors globally. Patients with progressive pancreatic neuroendocrine tumors were randomized to receive either everolimus, which is an oral inhibitor of the mammalian target of rapamycin, or mTOR, or placebo. So it was a high-quality, prospective, phase 3 double-blind study. Patients were obviously monitored very carefully for progression, which was the primary endpoint of the study. You can see from the Kaplan-Meier curves for progression that there was an advantage for patients receiving everolimus compared to placebo. A hazard ratio of 0.35, so a 65% reduction in risk of progression for patients on everolimus compared to placebo, which was highly statistically significant and highly clinically relevant. These patients all had low or intermediate grade tumors, and I'll come to the grading in a few slides. This has now become a licensed indication in 2011 and is available for patients who need this treatment. A bit like buses, two came along at the same time. Sunitinib was another study that was performed concurrently. It was planned to be a bigger study, but enrolled 171 patients. Again, patients were required to have progressive pancreatic neuroendocrine tumors, low grade, with evidence of disease progression within the previous year. Same design, placebo-controlled phase 3 study, and again you can see the magnitude of benefit seems to be very similar, with a hazard ratio of 0.42. Both of these, in fact, appeared in the same issue of the New England Journal of Medicine, and we were privileged to be involved in the study using sunitinib. But interestingly, the editorial that was accompanying them showed that these studies provide optimism regarding the treatment of pancreatic neuroendocrine tumors, partly because it's a new treatment option, but partly because we've now blown out of the water the myth that these tumors are far too rare for us to do proper, adequately powered prospective studies. So I don't think any of that is controversial, but there are some unanswered questions in terms of how we take this forward. What we don't know is, out of the patients, who benefits most. So currently, as on the left, we are treating mixed patient populations and seeing a benefit on average overall. However, what we're hoping to move towards is molecular diagnostics that will allow us to work out which patients derive the greatest benefit and actually remove patients for whom the treatment is associated with toxicities and side effects without any benefit. Other unanswered questions include the sequencing on therapies. The fact that these two came along at the same time has now left us as oncologists trying to decide, should we start off with everolimus and switch over to sunitinib, or the other way around? In fact, currently there are still only very few patients who have progressed on one treatment and crossed over to the other, but this gradually will become a greater population and we'll understand better how to sequence these treatments. But we're not just sequencing them with each other, we need to know how to sequence them with things like surgery, chemoembolization, interferon, other medical therapies, radiolabeled octreotide, or even how do we sequence them with episodes or gaps where we have no treatment at all. That's before we even start thinking about combining treatments together. So you can see that there's a role for a number of studies here to try and establish how best to use these treatments. Thus far, there is no evidence that we should be using these earlier in the disease, by which I mean in the neoadjuvant or the adjuvant setting. In terms of the neoadjuvant setting, the response rates that we're seeing with these agents is quite low. Most of what we're seeing is stable disease, and so it is unlikely that these tumors are going to downsize disease to render something resectable that isn't resectable at first staging. And we mustn't be tempted to start thinking that all neuroendocrine tumors are the same and apply the activity that we're seeing in pancreatic neuroendocrine tumors to non-pancreatic neuroendocrine tumors, including other ones in the GI tract, or indeed pulmonary carcinoid tumors. Where I do want to take you on to something that's a little bit more controversial is the anti-tumour effect of somatostatin analogues. Again, this was another development from 2011, which saw the granting from the EMA of an anti-tumour license for Octreotide. And you can see the license indication there is for patients with advanced neuroendocrine tumors of the midgut or unknown primary origin, where non-midgut sites of origin have been excluded. I want to take a few moments to go through this in a little bit of detail to work out whether this indeed is how we should be progressing with this treatment. Somatostatin analogues are not new. We're familiar with these. We've been using Octreotide for very many years. We know that the primary role of using somatostatin analogues is for the control of hormonal symptoms. And depending on which studies you read, symptoms are improved in up to 70% of patients, and we can also demonstrate a biochemical response and quality of life improvement in a similar proportion of patients. And if patients have got documented biochemically active tumors, which are producing carcinoid syndrome or pancreatic tumors like glucogonomas, gastrinomas, and so on, we know that this is a standard part of our armamentarium for treatment. It's also convenient that they're available as depot monthly preparations, which has made the administration of these treatments very straightforward. In general, they tend to be quite well tolerated. You can see the side effects there are listed, but most of the patients get on without many side effects at all. So let's look at some circumstantial evidence. James Yao and colleagues looked at the SEER database and identified 35,000 cases over a period of time from the 1970s through to 2004. The one thing they noticed was that since the introduction of Octreotide, there does seem to have been a shift in survival. Now, it's very difficult to attribute this entirely to Octreotide, as there clearly have been other progress made in terms of diagnostic, better immunohistochemistry, identification and classification of these tumors, but it's certainly tempting to think that Octreotide may have had some impact on survival. I'm not going to go through this in detail, but the first two of these references have gone through quite a lot of preclinical studies to try and work out what the mechanism of action would be for somatostatin analogues. We know that on the right side, binding of somatostatin 2 and 5 receptors by the somatostatin analogues can downregulate MAP kinase. And on the left side, we know that the somatostatin receptor 2 binding can reduce the activity of the PI3 kinase, AKT, mTOR pathway and reduce SHP1 signaling. So certainly in a preclinical setting, there is some rationale why there may be an anti-proliferative effect. On the left is the direct anti-proliferative effect that I showed you on the previous slide. On the right is the proposed indirect anti-proliferative effect. So the inhibition of growth factors and other trophic hormones, inhibition of angiogenesis, as well as immune system modulation. Some of these are yet to be proven. So moving on to clinical studies, you can see that back to 1993, there have been some studies using Octreotide, initially subcutaneous, and then with some of the later studies, some of the depot injections. In this table, we include in the final column response rates. SD stands for stable disease, and you can see that the main finding from the various studies is that patients achieve stable disease rather than response. So we're not seeing tumors shrinking down on the whole, we're seeing the absence of disease progression. However, we know that many of these patients have got very indolent disease anyway, so-called stable disease. And one of the limitations of all of these studies is that disease progression was not mandated at study entry. So it makes the interpretation of disease progression very difficult. Most of the studies included very heterogeneous tumor populations, including patients with neuroendocrine tumors from the whole GI tract, sometimes lungs, sometimes including high-grade tumors, and so on. So it can be then very difficult to interpret what's the benefit for the individual entities. Similarly, most of the studies included a whole array of patients with respect to prior therapies. Some were treatment naive, some were very heavily pretreated. The studies were fairly small, they weren't designed or powered to really evaluate tumor control, and none of the studies were placebo-controlled. So it's against that background that this German study was initially proposed. In this study, patients were eligible if they had midgut neuroendocrine tumors, or if on workup it was thought to be that the midgut was the most likely site in the face of an unknown primary tumor. Patients had to be treatment naive, so no prior therapies were allowed. They had to be histologically confirmed. Advanced disease, which was either locally advanced or inoperable, locally advanced or metastatic. Well-differentiated tumors, which were measurable by CT or MR. And in fact, they could be functioning or non-functioning, but they must not require somatostatin analogues. Because the randomization was a 1-to-1 randomization of Octreotide, and you'll be aware that the monthly dose is either 10, 20, or 30 milligrams. So this was going in at the top dose of the Octreotide every 28 days, or a placebo in a 1-to-1 randomization. Treatment was continued until disease progression, and the primary endpoint was exactly that, looking at the time to disease progression by blinded central review. There were a number of secondary endpoints as shown. My apologies to those of you at the back. This is a little bit of a busy slide, but I just want to take you through it in a little bit of detail to highlight a few points. Most patients, in terms of time from diagnosis, were about 4.3 months in the final column, although there was a difference between the two arms. One was 7.5 months in the Octreotide arm, 3.3 in the placebo arm, and I'll come back to the significance of that imbalance later on. Most patients were very fit. That's no great surprise. It was part of the eligibility criteria, but in fact, it's a reflection of how well these patients are generally. So 80% of patients had a good performance score. 60% of patients had non-functioning tumors, 40% had the carcinoid syndrome. You can see here they were balanced between the treatment arms. The primary tumor had been resected in most patients, around 65%. And the thing that's slightly different to our common day-to-day practice is the amount of tumor load within the liver. you can see that the vast majority of patients, approximately 75% of patients, had less than 10% involvement in the liver. And as an oncologist, that's not really what we see. We tend to see much higher tumor load involved. Patients were not required to have an Octreotide scan in terms of positivity, but 3/4 did have avid uptake when it was performed. And you can see, because of the trial eligibility, that the Ki-67 was less than 2% in the vast majority of patients. So we're talking 95 to 97%. I need to quickly just remind you about the classification because this is important. We have well-differentiated tumors, in which case they can be either grade 1, with a Ki-67 of less than or equal to 2%, and it depends on which classification you're looking at, what they're called in terms of neuroendocrine tumor or neuroendocrine carcinoma, but in essence, these are grade 1 tumors. You can also have intermediate grade, but still coming under well-differentiated tumors, and these are those with a Ki-67 of 3 to 20%. And then, of course, we have the high-grade tumors, and they're treated very differently, usually with chemotherapy up front. So let's go back to the PROMID study. This was the Kaplan-Meier curve for the primary endpoint, progression-free survival. You can see there is a very definite and early separation of the curves, and these are, in fact, quite impressive. This wasn't on conclusion of the study. This was, in fact, an interim analysis, which was mandated, pre-specified in the protocol after 64 events. And in fact, by the time it was done, 67 progressions had actually happened. So only 85 of the planned 160 patients had been enrolled. You can see that the median time to progression has improved from 6 months to 14.3 months, which is quite impressive. As I alluded to earlier, we didn't expect to see any responses, and most of the differences were, in fact, more patients achieving stable disease who were receiving Octreotide compared to those receiving placebo. And in fact, patients who had a low tumor load on the left, with a tumor load of less than 10%, seemed to derive the greatest benefit. You can see the Kaplan-Meier curves are very nicely separated. Those with a greater tumor load than 10%, there really didn't seem to be very much benefit from the dose of the Octreotide. Other exploratory subgroups, in addition to the tumor load being low, resected primary and good performance score were the patients who benefited the most. Although we could see that there was an improvement in both functioning and non-functioning tumors, regardless of elevation of chromogranin A and regardless of age. So on the basis of that study, the NCCN guidelines in the States in May 2009 updated their recommendations to include the use of Octreotide. And as I said, last year the European license was granted, and just to remind you, LAR for treatment for patients with advanced neuroendocrine tumors of the midgut, or effectively where you've got a presumed midgut on the background of an unknown primary, where all other primaries have been excluded. So, why controversial? Well, if you look at the detail of the study, the arms were unbalanced for this time from diagnosis. For patients who have more indolent disease, you'd anticipate there'd be a longer time from diagnosis to treatment. So it may be that patients in the Octreotide LAR arm already had more indolent disease. In practice, most patients don't have low-volume disease in the liver, and in fact, if you're thinking about an antiproliferative treatment, should you not have been given a higher dose for those with a higher volume disease in the liver? The vast majority of patients I've shown had a Ki-67 of less than 2%. So what do you do for the intermediate grades? Is it effective for that subgroup, or indeed should we be using a higher dose? And I think the main criticism of the study was that, in fact, there was no correlation described for whether the Octreotide scan was positive or negative. Moreover, patients at study entry did not have to have disease progression, so it's very difficult to interpret what stable means. There's been another very good paper came out last year giving us some guidelines on how to design the best clinical trials for neuroendocrine tumors. In terms of patient eligibility, we need to separate studies for carcinoid tumors and pancreatic nets. Well and poorly differentiated tumors should go into different studies. But one of the things they did highlight was that we need to mandate evidence of disease progression at study entry in order to make sense of stable disease. Progression-free survival was recommended as one of the primary endpoints, especially with the number of treatment options that these patients have. Overall survival can be difficult to interpret. But it did highlight the issue that we need to be mindful of the anti-tumor potential effect of somatostatin analogues. So we probably do feel that it's there, but I'm not sure the evidence is as strong as it's initially thought. So, the lessons from PROMID, what can we say? We can say that Octreotide, the long-acting analog, may have anti-tumor effect in mid-gut tumors documented by exclusion, newly diagnosed patients with low liver volume, grade 1 tumors only, regardless of functional status. But what we can't conclude is that this is just as effective in patients who have got higher involvement of the liver, greater than 10%. Is the effect the same in patients who are previously treated? What's the effect in patients who have non-mid-gut neuroendocrine tumors? We can't say what the effect is on progressive disease or patients with grade 2 tumors. All of those, however, would be currently covered by the current license. So just to finish, there are 2 studies that are coming along that might help us to understand this somewhat better. The first one is the Clarinet study, which is using lanreotide autogel, and the other is the Cooperate-2 study, which is using a newer analog, pasireotide. The Clarinet study, again, is a big study with 265 patients, and I've underlined in the eligibility box the differences to the PROMID study. So this study is for patients with mid-gut tumors as well as pancreatic tumors. Patients with well and moderately differentiated tumors are included, so that includes the grade 2s, but only non-functioning tumor patients are included, and prior therapy is allowed. So this gives us a much more relevant patient population to those that we have in real practice. Again, a well-designed study, lanreotide versus placebo, double-blind, and treatment continued until progression or death. This study has now completed accrual, and we should have the results of this by around this time next year. And the other study is the Cooperate-2 study. This is specifically for patients with pancreatic neuroendocrine tumors. They need to have demonstrated disease progression at study entry. Prior therapies are allowed, and again, it's for patients with well-differentiated tumors. And building on the evidence that I started off this talk with everolimus, in fact, all patients receive everolimus, but half of the patients allocated on a 1-to-1 randomization also receive the pasireotide monthly injection. So this will answer what the effect is of a stronger, more potent somatostatin analog over and above everolimus, specifically for patients with progressive pancreatic neuroendocrine tumors. This study is open in the UK, and if you do see potentially eligible patients, do feel free to look out the centre nearest to you so that we can have good UK accrual into this study. So just to summarise, I'm very mindful that as surgeons, surgery remains the only chance of long-term cure in malignant neuroendocrine tumours. The treatment paradigm is certainly changing, particularly for progressive low-grade pancreatic neuroendocrine tumors with the advent of new treatments. We do know that survival over the decades has improved since the introduction of Octreotide, and there is preclinical and some clinical data that a certain subgroup of patients may benefit, specifically those with mid-gut, treatment-naive, low liver volume, low grade, and regardless of functional status. But I think we still need to do some more research about the effect of Octreotide and other somatostatin analogues in the other patient subgroups, and the 2 ongoing studies may give us a bit more information. and I'd like to encourage you and your patients to participate in any clinical trials where possible. Thank you very much.